right, we will go ahead and get started. Hello, and thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button on the next to the raise hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for upcoming LHS events, there will not be a seminar in January 2024, and we will resume the series in February. And with that, I will turn it over to Dr. Genevieve Melanu-Mooks to introduce our speaker.
Hi, everyone. Genevieve Melanu-Mooks. It really is my distinct honor to introduce Dr. Julia Adler-Milstein, who I've known for quite a few years. She's a professor of medicine, the inaugural chief of the Division of Clinical Informatics and Digital Transformation, and director of the Center for Clinical Informatics and Improvement Research at the University of California, San Francisco. She's known for her research, which has really focused on health IT policy and specifically electronic health records and interoperability, and really looking at the policies, organizational strategies that can enable their effective use and better care for patients and populations as a whole. She's an expert as well in EHR audit log data and its application to studying clinician behavior. She'll talk a bit about that with us today. And really just to go over some of her impact, she's published over 200 papers, has testified before the U.S. Senate Health, Education, Labor, and Pensions Committee, is also a member of the National Academy of Medicine, has been named as one of the top 10 influential women in health IT, and has really won a number of remarkable awards, including being New Investigator of the Year through the American Medical Informatics Association, as well as the Alice S. Hirsch New Investigator Award from Academy Health. And so with that, it is my distinct pleasure to welcome her with us today.
Thank you so much. That was a lovely introduction. I'm really thrilled to be with this group, many researchers who I really admire, and a lot of you who I don't know yet, but I hope through at least being able to share my research in Q&A that we, if there is an opportunity to collaborate and relate what I do to what you do, that this will spark that. So this talk really does bring together, I'd say, many of the interests that Genevieve described in my introduction. And so, while I will talk about some specific research findings, the goal overall is really to weave together a broader narrative around how the evidence is coming together to help understand how electronic health records, clearly not by design, have resulted in this burnout crisis, but also to leave you with a more optimistic vision for how I think we have the potential to turn that around and not just not have EHRs contribute to benefit, but to burnout, but actually to help make clinical work feel more supported through working in electronic systems. So I have two parts to the talk. The first is trying to unpack this relationship between burnout and EHR work. There's a lot of, it's really been an explosion of work at this intersection. And so what I want to do is, again, take some of the individual research findings and try to build an overall framework to help understand that relationship. And then focus in my second part on, as I said, how do we practically reimagine the EHR as a tool that really can turn clinical work into something that feels more supported by the EHR. So let's dig into the first part. So I've one of the few cartoons that seems relevant to this world that we work in, where we know that the transition to electronic health records has not been smooth, and just in some cases it's just the basics of like learning how to type that have been challenging. But I think we know that there's even a deeper, more fundamental problem about the extent to which electronic health records have really felt like they've been able to to interweave with the complexities of clinical reasoning and clinical workflow, and patient interactions, again, to sort of make all of those processes feel that they can be done, better and more efficiently. In some ways, at the same time that we were rolling out electronic health records, we saw the emergence of clear evidence of increases in burnout. And so, some of these studies just show, right, the increase in burnout that was happening. And then really a series of studies trying to say, well, are these two trends related, right? The fact that we have more adoption of electronic health records at the same time that we're seeing greater burnout among physicians, are these two related? And so one of the first, I'd say, large scale studies that really caught headlines was a study that showed that basically clinicians spend almost half their time on what they call desktop medicine or working in the EHR. And that, I think that number really was shocking in many ways, and felt like, well, how could that not then be related to burnout if we know that, 10 years ago, clinicians might not have spent any time in the electronic health record because they were working on paper records, and now they're spending 50% of their time, split between seeing patients and working in the EHR. So this is just to show you that, like, not only are levels of burnout high, but there's even signals that burnout is increasing. Again, whether this is due to the electronic health record, the pandemic, lots of things that are happening all at the same time. But in results that we have worked with the American Board of Family Medicine to collect, and the advantage of these data is that they have 100% response rate because this is part of certification. You can see that in this last year of data that we have access to, we're seeing this actually, almost 10 percentage point jump in the percent of frontline clinicians who are reporting using a validated instrument that they are burned out. But again, I want to come back to this question of, like, is it the EHR or is it, other things that are happening simultaneously? And so, I do think that there are, many reasons to imagine that these two trends are connected. We know that there are issues with, the EHRs interfering in the relationship between patients and physicians. But then there's also questions like this second study that said, well, maybe we're just really missing the boat here. It's not the electronic health record, but it's the fact that we are operating in a highly sort of regulated billing focused system for which the electronic health record is just the vehicle that's delivering that. And so this study in the middle here in the Annals of Internal Medicine showed that, like, the length of notes in the United States were substantially higher than all other countries that were also on Epic systems. So they kind of took the EHR out of the equation by comparing the length of notes in health systems all on Epic in different countries, and really found that, the length of our notes were substantially greater. So pretty compelling evidence. Well, it's not the electronic health record, because here it is, the same technology system used across all these different countries. And then, sort of as the narrative evolved, it became, well, maybe it's not just the EHR in general, but it's, some very specific features of it, like, for example, inbox. And we know that, we push patients to get on the portal. We required through meaningful use that the patients had to be able to securely message their doctors. And so now we see this explosion in the expectation that clinicians be monitoring their inbox and responding to patient messages. And so some work we did showed that, how much time you spent after hours, right? So after you finish your workday, still doing EHR work, as well as just the volume of messages was associated with the exhaustion component of burnout, but actually not with cynicism, which is the other component of burnout. So perhaps these new tools are just simply increasing the volume of work that clinicians need to do, especially after hours, and that's leading to burnout through exhaustion. But again, these are just sort of, pieces of the story. And so, If you look sort of more broadly across all of the studies that look at this, we're starting to now see systematic reviews that are saying, okay, well, not just what do individual studies say, but what do groups of studies say? So multiple studies now have established the association between EHR time and burnout. So I think we can feel pretty confident that there is some kind of a relationship between those two factors. And in particular, it's not just the total amount of time on EHR, but it is the time on EHR after hours and the volume of inbox messages. So not just the one study I mentioned on the prior slide, but many studies that have now found that those are the particularly painful parts of EHR work that seem to be contributing to burnout. And if you then ask clinicians, like, well, what is the most important intervention for improving your well-being? This is not specific to EHRs, but just in general, I think this overall finding is supported by the fact that the number one factor that physicians rank is reduced time on documentation. That would be the number one thing that could most contribute to their improved well-being. As a result, there's been a major set of policy efforts focused on reducing physician documentation burden, as well as work within individual delivery organizations to figure out how to restructure teams and care processes in the EHR itself to do this. So I think we're now at a point in time where we can say we believe collectively as a country that there is a relationship between EHR time and burnout. Policy efforts as well as health systems are taking it very seriously, and we really are focusing on reducing time on documentation. And as I would say, the literature would tell us that's specifically important to monitor after hours and as it relates to the inbox. This is the study that, again, I showed you before about, that we still do believe this is a somewhat uniquely US problem. And so this is the length of notes in other countries on Epic compared to the US. Again, you can see all these other countries are down here in the tail of much shorter notes. But even within the US, right, that's like a massive, right, distribution, right? So who are the clinicians that are up here, right? What systems are those that have super long notes compared to those that are, like a third smaller in the number of characters. So again, we have sort of this funny problem here where we're not only higher, but we also have a lot of variability. And again, if you also look at comparing non-US to US health systems in terms of the total EHR time spent, you can see a lot of that is on notes, but some of that is also on orders as well as the in-basket messages, and probably the least difference in clinical review. So we can start to focus where we work on our improvements. And again, 60 minutes per day in non-US countries compared to sort of 90, right? That's a 30-minute difference. But it's not like in other countries, they're able to do their EHR time per day in 20 minutes. So there's still going to be a lot of EHR work, I think, no matter what, as just a part of regular clinical care. But we do have an opportunity likely to bring this down by a meaningful amount. So I hope that, again, that sort of tour of where we are with the literature has convinced you that we do have a problem to solve. Again, to some degree, this is just part of, EHR work is part of clinical care, but that the US has a unique problem in terms of both magnitude and variability. But we really quickly, I think, want to get to the question of well, what can we do about it? And what does the evidence say about what is associated with a lower likelihood of burnout, and are those specific to the EHR or not? So the literature here, I think, points to a few factors. So first is that that in this pretty large scale study, clinicians that agreed that the practice unloads clinical burden from them to usually other members of the team who are whose jobs have some component of documentation associated with it, whether that's an MA or other type of clinical support staff, is associated with a lower likelihood of burnout and lower burnout scores. And also the amount of clinician time spent on these prescription authorization messages, which are sort of the most perhaps mindless of the messages that clinicians get. Not all of them, but a lot of them are sort of just wrote I need another 3 more months of this medication, that the clinicians who had the higher volumes of those sort of low challenge, perhaps tasks that we could argue a clinician doesn't need to focus on, that they could unload that to someone else. Those are associated with higher odds of burnout. So if we look at what underlies both of those factors, it's really this concept of teamwork, right? Like thinking about the totality of EHR work and figuring out across a care team, like which work should be done by different types of individuals based on their unique skills and skill sets. So as we've dug into this question more deeply, we found that indeed teams that have a higher team efficiency have a much lower odds of clinicians on those teams being burned out. And you can see this is true across years, a really steady, solid relationship. And again, just reinforcing this notion of high home EHR use being just as problematic or being problematic in terms of burnout, we again see this very consistent, slightly increasing relationship in terms of higher odds of burnout for clinicians that report high home EHR use. So there's something here about this notion of teams being protective and again, reinforcing what other studies have shown in terms of high home EHR use. I also just wanted to note that in this study that we're working on right now, we did not find that relationships between EHR proficiency related to burnout. So this notion of like, are you savvy at navigating the EHR? That actually doesn't seem to be related to burnout as far as we can tell. So maybe that's one thing to take off the table for now is focusing on just training clinicians more into how to navigate the EHR more adeptly. But this notion of teams and ideally using teams to reduce high home EHR use seems more promising. So that may seem like great. You've just told us about, teamwork, but that's not that easy, right? To build the team, and what does even a really strong team look like that can help with spreading out this EHR work in ways that reduce burnout. So we found that high teamwork was most likely to be found in settings with a more stable workforce. So for example, independent practices are more likely to have that higher teamwork, rural locations. So it may mean that even if teams really are the key to this, there are particular practice settings that seem like they're having an easier time building those high functioning teams that can spread the work and reduce burden. Also, as we think about teams, low EHR work was most likely to be found in settings that gave physicians sufficient time for documentation and had higher proficiency. So again, while proficiency wasn't directly related to burnout, it does seem like maybe it is part of the story in terms of contributing to a lower volume of EHR work that then relates to burnout. So again, it's a little bit of a tricky, complicated story here, but we're trying to, unpack all of these relationships. So let me just pull back out because I just gave you a lot of different studies that talked about a lot of different things. And I want to sort of leave you with what I hope is a clear conceptual framework. So I think overall, we do now have a lot of evidence that the volume of EHR work contributes to increased burnout. And in particular, what type of EHR work? It's really the time after hours and the volume of messages, especially those low value messages, from a perspective of, is it worth a clinician's time to focus on them? So those prescription reauthorization messages. So that I think is quite well established. So then if we think about, okay, well, what do we know in terms of strategies that reduce burnout? So high team efficiency, so clinicians that say that their teams are highly efficient, those that report that their institution has really focused on how to reduce that frontline clinician burden. And last but not least, how do you actually reduce those low value prescription authorization messages? So again, research that points to those as being factors that directly reduce burnout. And then strategies that reduce EHR work are things like more time for documentation and greater EHR proficiency. So potentially reasonable to infer that if you are able to give clinicians more time for documentation or able to train them to become more proficient in the EHR, that could reduce the volume of EHR work, and maybe then that will flow through to burnout. Though again, we didn't see that direct relationship between greater proficiency and burnout. So another way then to think about these relationships, and again, this is more of a hypothesis based on those relationships I showed you rather than something that we've been able to prove yet in the data, is that it's the highly efficient teams that are able to reduce clerical burden, right? And that's perhaps predominantly through taking out some of these routine messages that can be delegated to another member of the team. that likely reduces the volume of low value messages, which can then reduce the amount of time that clinicians need to spend in the EHR after hours, and ultimately then the volume of EHR work to burnout. So again, trying to paint like a clearer picture of a causal pathway here between these relationships that I think the data is pointing us towards, even if we haven't been able to show that this is exactly the mechanisms at work. Another alternative, right, is you increase time for documentation or invest in more EHR training. Those more likely directly impact the EHR time after hours, which again then reduces the volume of EHR work or burnout. So I think if you ask me based on the evidence today, as we think about the relationship between EHR work and burnout and factors that could impact it, this is the best sort of causal framework I could give you in terms of where the opportunities are. And so on the one hand, I think it's great that the literature and the research has pointed us to, what I think is a pretty, logical framework. Like these relationships, to me at least, all make sense and are perhaps even obvious, but I think we still need to always be sure that there's the science behind them. But now that we have them, like, what do we do, right? So what are the options? Like, it would be, who doesn't want, right, a highly efficient team? Like, that would be great. But I think many places, because either they don't have access to a stable workforce or, a range of other factors, including the ability to hire, right, additional team members to support the clinician, there may be reasons that it's hard to achieve a highly efficient team. Increasing time for documentation, right? You go to most health system leaders and are like, could you give all your clinicians like an extra half day to catch up on documentation? And like, they would look at you like you're crazy. Like, there's no way that we could financially support that. So while it's helpful to know that that is a factor that could help, right? It's just not something I think, unfortunately, that feels feasible at scale. Again, some opportunity there, but it's not like, oh, well, now that's the magic bullet and we'll just give clinicians all this extra time for documentation. And investing in more EHR training again is certainly an option. Here at UCSF, we're actually about to do a whole push to upskill our clinicians on how to work in our EHR. But again, it's expensive and it's costly, and in terms of taking clinicians out of work and being disruptive to their clinics and clinic schedules. So it's like not a silver bullet either. So none of these, I would say, are like, feel like a totally satisfying answer in terms of what we can practically improve. So again, I think really helpful to understand those relationships and where there are opportunities to rethink how we approach EHR work in ways that should reduce burnout. But I want to introduce a different framework here that I think holds promise and perhaps avoids some of the practical downsides of the other strategies that the literature is pointing us towards. So now I want to move into the practically reimagining the EHR part of this talk. So sometimes I wonder, like, is the optimal solution hiding in plain sight? And if you look at other industries, right, if you say, like, well, how does Amazon design its platform? Or how has Netflix gotten so good at figuring out, right, like what it is that I want to watch next or what my kids want to watch next? And why is it that our iPhone is like so delightful and something that is like so helpful? I truly can't imagine getting through the day without my phone, right? And there was I remember a good chunk of my life when I didn't have a phone, but now it's something that I so rely on and it feels like makes my life better and easier. There's some downsides to it too, but by and large, most of what I get out of my phone is like, it allows me to do more in my day in a more sort of efficient and effective way. So like, what is it that these companies are doing? And like, why have we not been able to figure out how to do that in healthcare? So the main thing that these companies do is they actually use the data from the users on their site to try to understand what's working and what's not, and then they change the software to try to improve it. And so, Apple collects lots of user data, Amazon collects lots of user data, Netflix collects lots of user data, and all of them have a very scientific process to try to understand like whether the user interactions with their software are being optimized. And if they think they're not being optimized, they rapidly change the software to improve it. And then they can, because they're gathering so much data all the time, figure out if it worked or not. And then if it worked, great. And if it didn't work, continue to refine it until it gets better and better and better. And this is just a concept that we haven't really invested in healthcare, is sort of using our frontline user data to try to understand, right, whether we have designed the electronic systems, workflows, right, user interface designs, all those components in a way that's really trying to optimize, workflow efficiency, ability for clinicians to absorb information. So, so we tried to, think about using the data that we have. Like, is there an opportunity to really reshift our focus on, I guess, what broadly could be called like usability and usability of individual EHR functions, using the same model from other industries, and using data on users to try to target where we should be investing in retooling EHRs. And so we started with this sort of conceptual model that tried to put together these different relationships. And we were curious, like, so if we ask clinicians about usability of individual EHR functions, you can see what those are, like ease of entering EHR information, reliability, amount of information presented, some of these sort of classic problems that if you asked, Amazon, like, are you thinking about like ease of finding information on their website? They would say like, yes, that's something that we try to optimize for. So can we show that usability of individual EHR functions are related to overall EHR satisfaction? And then we know that that is a factor that also contributes to burnout. But we were also curious because a lot of the things that health systems are investing in are things that are almost workarounds to usability, right? Like scribes or templated text or voice recognition. And so as we were thinking about looking at these relationships, we said, well, we also really want to understand whether these burden reduction strategies that sort of buffer frontline users from poorly designed EHRs, like, are those working? So at least we could know, like, well, even if your EHR has poor usability and you don't want to work on improving it, could you at least use these burden reduction strategies as a workaround that could achieve some of the same effects? So again, this is a conceptual model that we're working on testing right now with our national physician survey data. And interestingly, what we find is that while we do find that strong relationship between usability to satisfaction to burnout, we are not finding that those burden reduction strategies are effective workarounds. So basically, even if you are investing in sort of scribes or templated text, et cetera, it doesn't seem like it's really moderating the relationship between usability and satisfaction. So it does suggest that this usability problem is something that we really do need to address because it is contributing to satisfaction and burnout. And again, it's just not something that I think we focused as much on addressing, is how do we use the strategies that other companies have shown are so successful in designing good software and bring that to the world of EHRs. So again, this is one thing I hope you take away from my talk. It's that I hope we do sort of return to this notion of the importance of building good software and improving usability and using the data we have on frontline users as a strategy to improve usability. So usability is a complicated construct, and I'm not going to, in my talk today, be able to give you everything you need to know about usability. But I think there is one pretty simple distinction that is important to think about. And that is the difference between user interface design, which is context independent. Like pretty much anytime you touch a piece of software, it should adhere to principles of good user interface design. So this is things like font size and icons and colors and contrast and layout. These are things that we just know all humans need to be able to interact with software effectively. And again, I think the lowest hanging fruit here is just to think about how EHR user interface design can be improved in ways that are context independent. That's in some ways the easy stuff because it's context independent. Much harder is this notion of usability to engage in cognitive task support, because that is context dependent. So those are going to be things like workflow design, visualization, memory aids, error anticipation. And we know in healthcare that context matters deeply, and probably much more so than it does for Amazon, Netflix, even your iPhone, though I think they also do some interesting context dependent work there. But right, in healthcare, you can like have a patient that looks very similar to another patient, but there's some very nuanced piece of context that matters. And so you may need to design that workflow a little differently or show that information visualization a little bit differently. So there's a deep science that I think needs to be developed here to really understand this world of cognitive task support as a form of usability that can kind of speak to how do we help, ease finding of information, right? Because we know that's a broad task. All clinicians need to do it. But if that needs to be done in a context dependent way, how do we understand what sort of, cognitive task A, how that information finding support should look different than task B. So again, I don't want to pretend like this is going to be easy, but I think it really is a critical science to be developing, even further in our world as we think about how do we, try to tackle this overall crisis around burnout and the EHR as a contributor to it. So this is the last section of my talk where I just want to give 3 examples of what I think this could look like, and how can we do this work in ways that are both, like practical and feasible, but that could really have a large impact on the clinician usability of EHRs in ways that could reduce burnout. So let me start with my first example. This was a study that came out in JAMIA now a couple years ago, but I think is just really illustrates the value of like using the data that sits in the EHR around user interactions in ways that can bring insights into how to redesign the EHR in ways that better support clinicians. So we were really curious when we observed at our own institution, just a normal upgrade that our vendor provided, had nothing, like we didn't do anything special here, but they made a user interface design that basically moved a set of information from one screen to another. It kept it on its old screen, but it newly moved it to a new screen. And this specific information was outside records. So as you may know, at Epic institutions, they have built a way to see records from other Epic institutions. And for a long time, you had to go to like a separate tab to look at those outside encounters from other Epic sites. And then at some point, Epic's like, well, maybe we should just move this information and also put it on the encounter tab so you can see a complete list of encounters, both at the local health system and outside. So again, at University of Minnesota, what that would look like is one day you go to one place to see a list of all encounters that happened at University of Minnesota. You go to a different tab in the EHR to see all other outside encounters. And then the next day when this user interface design change happened, all of a sudden, when you go to that place where you used to only see the University of Minnesota encounters, you now see a list that combines the two. And so we were curious, like, okay, well, they just moved, this piece of information to perhaps a more intuitive place. And so did that increase how often clinicians looked at outside records so that they could understand what's happening with their patients in a more comprehensive way? So again, this is just the screenshots, what it looked like before. You would go to this Care Everywhere tab and you'd see, oh, this patient had an encounter at Glacier Edge Clinic and River Hills Health System, but you wouldn't see that local data here. And this is the Encounters tab, where again, prior to this user interface design change, you would just have seen your local health systems encounters. But after the change, what you can see here is all of a sudden, you're seeing these new encounters populate chronologically on this list that have this little E next to them. That means that they were outside encounters, but we're just showing it to them on this new screen where they didn't used to see it before, where then they only used to see the local health system encounters. And then the cool thing is you can actually mouse over this particular row and see the associated data for that outside encounter. So not just that it happened, but also like what happened during the encounter. So get that clinical information right in the right place. So all we asked was like, well, after we implemented this upgrade and that information moved, like, did we see an increase in how often our clinicians viewed outside records? Say pretty dramatic, right? Like you do not need to have an advanced statistics degree to see that this had a major effect. And if you do run the interrupted time series model, you can see that it was a significant increase of almost 30,000 outside record reviews per week, just at our institution, right? So we just had made one little change in the layout of information, and like a vast increase in how often outside records were reviewed. And then the cool thing about the data, right? So this is the EHR user data that Epic makes available to access, is that you can see that the people who went to the old place for that information actually didn't go down. So if it was in their workflow to go to that outside records tab in the system, they still went there. We don't see like a substitution effect. Really what we see is like this brand new pathway being used by, a large set of people who probably either didn't know or didn't take the time before to go look at that other tab. But now that it's in their sort of main encounters tab, they're taking the time to look at those outside records. So again, we can see very directly that it was this new channel or this new place to put information that had such a big effect. And then you can do other cool things like break it down and say like, okay, in what setting did it have the most, the largest effect? And this is starting to build from sort of perhaps a context independent way of thinking about this to context dependent. And maybe you'd say, well, in the emergency room, we actually like this change didn't have as much impact as in other settings. So we could look at it both from an absolute sense as well as on a per encounter basis. And so what you see on a per encounter basis, the largest increase came in the inpatient setting, where there was 2.15 additional record views per encounter after this change went into place. And we interpreted that in the sense of like, we think the emergency department like was already pretty good at looking at outside records because they just had, they were used to that because they had to be in the emergency setting where understanding what's happening with your patients and where they've seen care before is so critical. And in outpatients, it's probably not as critical to get that outside record at the point of care. Usually you're seeing your patients for, more routine things. So that outside encounter data might not be as important. But in the inpatient setting is the in-between where those outside records are likely important, but on the margin, perhaps the inpatient teams weren't taking the time to look when it wasn't in as clear a place. And now that it was in a more obvious place for them, that was where they saw the biggest bump. Again, these are just hypotheses about why we're seeing these differences. But again, it's helping us build towards this context dependent in understanding of these relationships. Okay, so that was the first and most detailed example that I will give, just how a simple user interface design change really had a huge impact on provider behavior. And again, coming back to this notion of the importance of usability, right? That our clinicians are in the information business. And if we can do things that help improve the speed or effectiveness with which they can rapidly understand information in the EHR, that's likely to have a huge impact on their, ability to not only be efficient, but also be, effective and safe. And so if we can use our research skills to help improve usability, specifically around information uptake and visualization, et cetera, I think that this is going to go a long way towards ultimately, improving clinician work as well as reducing burnout. So let me just give you another example of this that comes from a different group, not my own, but when I saw this example, I thought, oh, this is really cool and really fits this, my mental model of the kind of work we should be doing to help understand improvements in the EHR from a usability perspective. So order sets, for folks who don't know, are basically an efficiency focused intervention to say, well, for a given clinical condition, if clinicians usually order the same set of 10 things together, let's just group that into one order set so they can pull down all 10 at once rather than having to go and individually place 10 orders. So pretty simple idea. But whether we got that group of 10 right at the start, we don't always know. There's no science, necessarily for saying, okay, like what is the right combination of orders to put together into an order set. And so usually you start with expert opinion that says, okay, like for this condition, let's build order set 1. And for this other condition, let's build order set 2. And for this other condition, we'll build order set 3. And then you can always customize by adding or subtracting orders from a given order set. Well, once you deploy these order sets, you have the ability to study, right? How often are people adding or subtracting orders from them? And that's giving you a signal of whether you've designed, right, usable order sets. And so ultimately moving from just deploying order sets and letting them be static and people just change them or not, never really knowing if you got them right. Let's use all that data on what people are doing with order sets in the real world to be able to dynamically update order sets, and ultimately get to a place ideally where they reflect, sort of the best optimization of, combined orders. So a group at Stanford helped sort of build us towards this by suggesting what these measures of real world use could be that could help guide refinement of order sets. So for example, like when should you consider removing an order from an existing order set? Well, you can look at like infrequently ordered items within each order set, right? So the number of orders for a given item divided by the respective number of order set uses should tell you, okay, that's probably, an item that we could consider removing. Another measure is rapid retraction, right? So someone that puts in all the orders in an order set and then very quickly takes one of them out, right? Which is again, a concern, right? That maybe you put something in the order set that should be ordered some of the time, but not often enough, but that a clinician may easily miss that. And so put in the order set, realize that one of the orders was incorrect and pull it back out. So again, some interesting measures of when to take pieces of order sets out. What about adding things to existing order sets, right? What if you didn't get the full set right to begin with? So you can see how often clinicians are adding orders to an existing order set, right? So an a la carte order that's not part of that order set occurring within 10 minutes of given order set use. Pretty strong signal maybe that if you're seeing a lot of that a la carte ordering related to a given order set, that maybe you should try to add that order to the order set. And then again, you can then use your removal metrics to figure out if you got that right. And then there's also just sort of a like what to investigate. So what if you see a la carte orders that are part of an order set co-occurring within 10 minutes of given order set use, right? So that's like something weird is happening there because that order was in the order set, but then it's also happening as an a la carte order, right? So it feels like there's something there that you could help investigate related to usability. So again, I think this is just a cool set of measures, very practical, that could be implemented around order sets to help give more guidance on real world use and refinement and moving into this notion of optimization. I'm just going to add my third example. This is not even nearly as fleshed out as the other two, but just as a way, as we move into the world of AI, to think about what does usability of AI tools look like, particularly in the world of diagnostic reasoning, where there's such an important set of activities that clinicians go through to arrive at the right diagnosis by sort of slowly winnowing down options for diagnosis and uncertainty to get to the right diagnosis. So this is really just a framework that we developed with a set of experts and thinking about like, well, what is the diagnostic reasoning process when you look at it, right? It's not that a patient comes in and presents with signs and symptoms and then like you get the diagnosis, poof, right? Which is mostly how AI tools work, where the AI prediction goes straight to that final diagnostic label. And it just misses, right, all of the clinician's reasoning process through which they first gather information, organize it, prioritize it, and then integrate it and interpret it, and then make a plan for next steps. And then basically slowly, and not slowly, but just go through these cycles methodically until you arrive at the final diagnostic label. So if all of our AI tools just jump to the end, right, they're not likely to feel like they're really supporting the clinician's process. Instead, we should be thinking about how can AI tools do a better job of supporting information gathering, organization, and prioritization. And then the AI tool could think about moving on to the next step of the integration and interpretation, perhaps suggesting potential diagnoses. And then an AI tool that could help with formulating the next steps, right? So here's a ranked list of potential next steps for the clinician to consider. And so that if we think about these fundamental frameworks of how clinicians work with and understand information and build AI tools meant to support those, much more likely to be sort of accepted and helpful as opposed to tools that basically just jump to the end of the process. And for which, again, some cases that might work well enough. But I think, in many cases, if we ignore the underlying diagnostic reasoning process and how AI tools could support the different components of that process, much more likely to get tools that are well accepted. Okay, so that was, I hope, both, enough of a set of frameworks and ideas that you can walk away from this talk understanding what we now know about the relationship between burnout and EHR work, and also this set of work that I feel passionately about how do we use data on how EHRs are being engaged with, day in, day out as they are supporting care, and identify opportunities for improving usability so that EHRs become a tool that really support clinicians in their work and doing these fundamental tasks related to information gathering, information processing, and decision making in ways that, again, combine the best of human reasoning and AI and other data tools. So with that, I'll just say if any of this latter work has been interesting, we have this incredible growing group of researchers across the country who are working with EHR metadata and doing studies like the ones that I mentioned, like the Care Everywhere study. So if you're interested in getting into this realm of research and better understanding the data you may have available at your own institutions to do this kind of work, here is one opportunity to join our group and to learn more about this set of research. So I will stop there and would love questions, comments, reactions.
Great. Thank you, Dr. Adler-Milstein. That was a great talk. We have about 5 to 7 minutes remaining for Q&A. You can either, to our audience, you can either put questions in the Q&A or the comments, or raise your hand and ask your question that way. We have a couple comments. Rubina says, great talk. Just a comment. What I have learned talking to EHR end users is often less is more. Having EHR with minimalist designs, needing fewer clicks navigation to perform certain tasks, less text, and maybe more visuals and customized training for clinicians based on their technology skills could do the magic. This entails involving users in SDLC and as well as creating training materials.
Yeah, I think it's a great comment. And I think overall, those can be some North Stars for how to do the redesign work. And I know there are programs, I think started at Vanderbilt, others called Clickbusters, like what is a process in which you think you're doing too many clicks, and then they'll come and help kind of figure out, where that can be taken out. And so I think that yes, I know it was just a comment, and it's a comment I resonate with. And I think those can be some of the useful North Stars, as well as processes, as you're suggesting, to engage in to help move towards this model.
We have another comment from Paul. He says, excellent, or they say, excellent point on ease of accessing data. Our EHR went from having a synopsis that showed all meds administered in the last 7 days on one screen with ability to click on each one to see last day time administered. Now, the same information is available in the MAR, but requires nearly endless scrolling for complex patients and multiple rows with no administration in the last 10 days.
Yep, seems like a clear opportunity for sort of reworking that user interface design for it sounds like complex cases. And again, that's where the context dependent piece will come in, right? Like if you need to know that nothing has happened, rather than scrolling through 10 rows of that, how can you condense it, but also make clear that, that there is, no activity over a longer period. Again, I think these feel to me all like solvable problems, and we just need to identify them as problems and then, be able to work, engage with, frontline users or whoever it may be to think about a better user interface.
Don says, thanks for shining a light on these issues, wondering about impact on information blocking requirements and also revenue cycle.
Yeah, so if I'm understanding the question correctly, like the impact on information blocking, I may need a little more help so I can understand exactly the question you're asking. Whether you're asking about sort of like whether we could be studying whether information blocking requirements are impacting some of these usability things around outside records. That's a really interesting question. I hadn't thought about that. And with information blocking, presumably there's going to be a lot more information coming into the EHR, both because of information blocking and TEFCA and kind of other pieces. And so I think it would be a really interesting opportunity to think about, in general, I think we just need so much more work on how do you integrate lots of outside record information into the EHR in a way that the clinician can easily navigate. And I think that problem is going to get worse in some ways as more information is made available because of info blocking regulations. But I think we could simply, be able to use, like a repeat version of our study to understand that. As a simple first step, but I think there's a lot more to think about as we try to triangulate between the impact of the regulations, the impact on user interface design, and try to get towards a better framework for usability of outside records. So that's an interesting set of ideas that I had not all put together before you asked your question. So thank you for that. I'm not sure I have super insights on revenue cycle, so you may need to tell me more about that, and maybe I could say something more.
Well, that was what they were asking.
Okay.
There's a question about, does the NRN EHR audit log data also include patient portal usage data as well?
Yes, definitely. Most large EHR systems like Epic and Cerner and others, like part of their metadata structure is all the portal metadata. So like we have done some studies with that, understanding like what patients are doing on the portal. So yes, if you're interested in patient portal interactions, all the secure messaging metadata, like there's lots of opportunity in sort of the patient care team interactions through the portal, and some folks within the NRN who have really specialized in those data, and I think could help answer any questions.
Well, Rubina says wonderful based on that. And she also asked the question. There's a question, do EHR systems provide tools similar to the website optimization tools, for example, Optimizely, that make it easy to modify the interface and then test the changes?
Yeah, so it's a great question. Again, they're not national standards here. So it's not something that all vendors provide. I'd say like within the Epic world, which is the one I know best, they have some pieces that you can modify. Like there's some things that an individual can modify. They can be like, turn this on or off, or I do or don't want to see this. So there's some sort of, usually in the form of checkboxes that clinicians can set at the individual level, or other optimization or modifications that individuals control. At the organization level, I would say much less so. There are options for how organizations can sort of customize, but I wouldn't say that they're quite at like an industry standard level for how to do optimization work. So I'd say they are more resource intensive and clunky. So I think there is a big opportunity to study some of the clinician level tools that allow clinicians to modify and to see whether, in fact, clinicians who spend more time optimizing their own user interface, are happier and do better. Whether even we should train clinicians in how to use those better, I think is a totally unanswered research question. So again, I think there is opportunity there, but also opportunity for this to come up to more of an industry standard approach.
All right, we have time for one last question, and this one comes from Dylan. They say, great presentation. The ONC has the certified healthcare IT product list that is EHR certification. They saw that Dr. Raj Watwani on your slides. Is there a model linking EHR certification to usability and user satisfaction? Like using your model based on volume of EHR and time on EHR for desirable task completion and less burnout, or like using your research model for standardizing EHR certification that might include cognitive task support?
Yeah, so great questions. So I would say that in general, there are like a few things within EHR certification and things that you could find in the chapel that relate to EHR usability, but they are pretty basic and I don't think really represent like a rigorous approach to assessing which products have better or worse usability. So like, you could probably explore that, but at the end of the day, I'm just not confident that that structure has really pushed EHR vendors to really invest in more usable systems. So then I think kind of the next question is like, well, what are good sources for understanding these relationships? I mean, for a long time, the EHR reporting program was sort of the policy strategy that was purported to be the one that would like get frontline feedback from users, and you could then develop measures that hopefully then the EHR vendors would either feel pressured to respond to, or they could have built that into policy. But that program has never really come to fruition, in part because it actually is really hard to rapidly collect that frontline user usability information and turn it into systematic measures. So I think, again, frankly, that has struggled. So we don't have a lot of opportunity to do this work at scale, which is not great, but I think is the reality. And so most of the work on this, I'd say, is more coming from individual institutions using their own data and trying to establish strong evidence for the relationships between improved usability and different kinds of outcomes. And that really is the state of where things are today. So again, I hope we can move towards doing this work at scale, but I just don't think most of what we have today supports that.
All right, well, thank you so much, Dr. Adler-Milstein. This was a great talk. And again, in closing, everyone, please join us in 2024 on February 6th at noon. And this now concludes our presentation. Thank you.